We're here today with the Utah Valley Structural Heart Team. First, quick introductions. Wanted to introduce Mitch Southwick, the Cardiovascular Operations Director, Kristen Keaton, Cardiovascular Supervisor, and Dr. Nirmal the Medical Director and Structural Heart Cardiologist. To start things off, Dr. Sankara, can you tell us a little bit about your program?
Yeah, thank you for that introduction, Alex. We at Utah Valley have a big structural heart team. We're lucky enough to be representing them today. We have a structural heart team composed of cardiac surgeons, interventional cardiologists, cardiac nurses, cath lab team, OR team, administrators, and the clinic medical assistants, including Liz Baer, our structural heart coordinator. We started our program in 2020. Mitch spearheaded the start of our program along with our cardiac surgeons here. And we've grown significantly through the efforts of all of our team members. We yesterday implanted our 500th transcatheter aortic valve inpatient. And this is a testament to the efficiency and the hard work of the team that everybody put together. And I'm extremely proud of everybody to have gotten this far within a short period of time.
So let's talk a little bit about aortic stenosis. When you see a patient, what types of symptoms are you looking for?
So aortic stenosis is a problem of the aortic valve within the heart. Aortic valve is a one-way valve that sits between the bottom left pumping chamber of the heart, which is called the left ventricle, and the main pipe, which takes blood all over the body, called the aorta. This valve is supposed to open with each heartbeat and close, preventing any backflow into the pump. This valve tends to degenerate over time. When we are born, the leaflets of the valve are pretty thin. They're about maybe thinner than this piece of paper. But as we get older, they tend to become thick and brittle. And when they become thick and brittle, they don't open as well as they should. And sometimes they don't close as well as they should. So when the valve doesn't open, the pump has to work extra hard to push blood across that valve. And that means that the body is not getting enough blood, or the heart is working too hard to even pump a little bit of blood to the body. This manifests in a few ways. Sometimes it is chest tightness or shortness of breath when people are walking around because they're not getting enough blood when they start to walk or exert themselves. If there is not enough blood going to the brain, it causes people to have dizziness and people to pass out, especially when they're exercising or exerting themselves. The heart tends to give in over time, meaning that the pumping chamber itself becomes weak. And when it does become weak, it tends to not be efficient in terms of pumping blood. So all these other problems become compounded. And when it becomes weak, it also tends to back up into the lungs. So people develop shortness of breath when they're laying down. They tend to have difficulty breathing when they go to sleep. Sitting helps breathing. People feel better when they're sleeping in a recliner or sitting up. And then people start noticing swelling in their legs, which again, once aortic stenosis progresses to this point that there are symptoms, it tends to lead to ultimately death within a short period of time, which is about 6 months to 2 years once these symptoms develop.
So I think you answered the question here, but just to reiterate the point, if a patient is exhibiting symptoms, why is it so important? And how quickly do you want to make sure that you are evaluating them and referring them for treatment?
Again, once symptoms set in with aortic stenosis, it's a very short period of time before the heart is not able to keep up and gives in, which leads to mortality or death. And that's why it's really important once we identify aortic stenosis to treat them either as soon as symptoms start or as soon as we identify these symptoms. Are we having these guys ask questions? Or?
Yeah, please.
Yeah. Sorry, I'm distracted. she pointed at me, and so I'm all distracted. Did you see something that you wanted us to change?
Yeah.
Why?
Something going on.
Since we're in a break.
It says light sensor. I think it's something about the TV that was behind you. So
It's I think it just takes some LA. Yeah, you guys please ask the.
Yeah. So real fast, you want us to ask questions that you're saying?
Yeah.
Okay, Kristen, let's have you start. Let's refresh. Give it a second so we can clean the
Good
edit.
dry run. Feel free to just
Yeah.
go back and ask the same questions. I think those were good answers.
I agree.
So you have questions in front of you if you want.
I don't think I do I?
You do have some.
He just asked those questions.
No, so let's cut me out. I don't want to
Do you
be.
want to do this one?
These two.
These two?
Or yeah, I mean, you can share this and then
Yeah, put it right there.
Okay, we'll share this one.
All right, so let's assume we just did the opening there.
Yeah.
no, we did. We can use those two questions so far, and then we can
Yeah.
keep going.
Sure.
She wants to fix something. Go ahead.
probably something on the TV.
It's the TV, so I think it's picking up the light fluctuations and it adjusts the brightness. I don't know if we're gonna.
Get away from that. Can you edit that pretty easily behind the scenes?
And it says in green
It's not
letters
coming
of
through
font,
that
light
camera
sensor
too
with
much.
little green leaves.
It's probably visible in that one. Probably a little visible in this.
So we just switch the angle. So.
Let's start with this
I
one.
guess it would be better to not have it.
Okay. Yeah.
It's too
Yeah.
distracting.
I don't think that we talked about the types of.
So do you want to rerun those questions?
I don't think so. I think we can use those
Sure.
questions. Yeah.
So we just did importance to treat, urgency. Now, Kristen, you want to
Yeah, I'll
ask
start with
kind of the
the-
next one? Yeah, like
Yeah, the valves.
what are the options here?
Okay, so if you.
Let's
I'll give you a,
Okay.
give you a quick countdown and we'll.
And then we'll go.
Yeah.
Straight.
All right. And 1, 2, 3.
Okay, so Dr. Sankara, if you are a referring physician and you're seeing a patient with aortic stenosis, what are the current treatment options available for them?
Yeah, aortic stenosis traditionally was treated with valve replacement through open heart surgery. More recently, in the past 15, 20 years, we've had extensive development in that field where we are now able to implant valves without doing open heart surgery. This is called minimally invasive valve replacement. We do that through typically by going in through a patient's leg and implanting a new valve. Sometimes if for whatever reason we're not able to use the leg, we can use other access areas like the neck or the shoulder area to access the aortic valve and replace an aortic valve. So this technology is currently available as well.
You know, if I could just add to that too, Dr. Shankar, it's interesting. Open heart, it's often referred to as TAVR, but it's basically a surgical aortic valve replacement. And nationally, you see a trend where TAVR, or surgical aortic valve replacement, has actually been trending down historically. One of the nice things about our geography here in Utah is we have a growing population, so we don't see that same significant trend. But what we do see, which is a national trend, is TAVR, or transcatheter aortic valve replacement, is drastically, or at least increasingly growing, which again aligns with the national trends, and it really is a testament to the success, particularly the 5 to 10 year data that we're seeing. You know, as TAVR is still relatively new, we'll see how the 15 and 20 year data comes, but for now it's a great option for a lot of patients. Previously, and some of the stuff we can talk about today is previously you would only do it on non-surgical candidates, right? And now as the FDA and our government officials and Medicare, Medicaid, and all these folks, CMS, continue to see the value of it, it's becoming lower and lower risk patients that are getting that authorization, that approval, which is just giving us way more tools and capability to support. And the other thing that's fascinating too, that and you hit on this earlier in some of the dialogue, is, you know, 15 years ago, all you could do was get pretty extensive in surgery, right? I mean, an open heart surgery is nothing small. It's a big deal. And we won't expound on that necessarily right here, but basically you have to actually go in through the chest cavity and do some incisions. And now with, you just go in through the femoral artery and you come up and you just release that little balloon and all of a sudden you have a new valve. It's pretty fascinating, the technology we've achieved at this point. So.
Yeah, that's a great point. In terms of volumes, this was originally surgically treated. So there was this sense that once you get to a certain age, this is not a treatment that's available for you. This is not a disease that could be treated. But I think we're lucky to be living in this day and age where we're able to offer this therapy to patients to whom it was not available before.
One of the things too that, and Dr. Shakar, you can speak to this, it's fascinating. Every patient does not have the same heart, size, capability. The valve placement has to be different, right? Maybe talk a little about how you go about strategically planning that, the imaging technologies and so forth that we have to utilize.
Yeah. You're right. Not every valve is the same size. Not every valve is located the same. You have to take into account the surrounding structures when you're planning for this. So there is a lot of thought that goes into picking a valve, the type of valve and the size of valve for a particular patient and the access approach for that patient. We do extensive imaging before the procedure. We do CT scans from the neck all the way down to the leg to understand the internal anatomy, as well as understand the type of valve, the size of the valve, the relation of the valve with the surrounding structures. And once we have that assessment, then we sit together as a team and we discuss what is the right option for this patient. A lot of thought goes into picking this type of valve for the patient, not just current situation and current anatomy, but future considerations as well. You've touched this before. This valve, this technology is now approved for lower risk patients. What does that mean? That means traditionally people who are younger, who do not have high surgical risk, who would be great candidates for surgical aortic valve replacement, can potentially opt for this treatment as well. This is available for them as well. Now, when offering this to them, again, this is where our team does a great job, is the thought that goes into offering a particular procedure or a valve for these patients. You have to not only consider the immediate procedural risk and the recovery times, but you also have to consider what could happen in the future with these valves. Now we have good data that these valves do well up to 10 years. Like you said, we just don't have the 15, 20-year data yet, which we'll potentially have in the future. So what should we do if this valve were to not function as expected at 10 years? So that goes into our thought process as well when we are planning a particular valve for these patients. Again, that's where I think our team shines, is having that discussion as a team, deciding on what particular valve suits best for that patient situation. Now, this is obviously done with the patient's input as well. Patient preference does matter in this. If a patient were and we present these options to the patient, and ultimately we have a discussion with the patient as to what the best next step for them would be.
Kristen, what do you find with patients specifically as you start getting referrals and people call into the clinic? Maybe talk about the flow there a little bit and what you see from behind the scenes. Like what questions they asking you specifically, Kristen, or the staff, Liz?
I think, yeah. Oh, sorry.
Before she answers, I got her. Just trying to engage everybody.
This is you guys are
Doing a great
killing
job.
it. Yeah,
This is awesome. Didn't even need a script.
I don't think this is on the question list. Maybe.
we're off.
I don't know,
You guys
guys.
are
I
all
have to
good.
prepare for this. I feel like
Do
patients
these
ask.
need to be off
Do you
the
want to take a
table?
second to collect your
Yeah.
thoughts?
Do these need
Yeah,
to be
a
off
little
the
bit.
table?
Okay.
You can be all
You can
admin.
mention Liz.
I just
wanted to
freaking cable sitting on
Typically,
there.
once we get a referral, we involve our
Here,
team
put these-
We have
coordinator
a
who is
structural heart
listed.
MA.
Put these in your hands
And-
real fast.
Maybe, yeah, and I'll throw this one out. Maybe you guys can talk about risk benefits after this to
Yeah.
like why do patients want TAVR, or what are the what are they? Yeah, you guys are.
I think that patients tend to have a lot of questions, which is why we have kind of.
Hold on a second. I want you
What?
to take this off the table.
Okay.
All
So
right,
the
we'll
cable's
do
not
a
there.
countdown
Okay.
and ask her the same
Yeah.
question. All right,
Yeah.
one.
Wait, what was?
It was some questions that patients
Yeah, I was
are.
flowing with the question. Can you keep?
She
can you
was
use the
flowing.
question or
You can
no?
use the
There's no-
question,
I'm
right?
not flowing.
You're here to
Oh, okay.
Yeah.
I forgot
Okay.
the question. I was flowing.
basic questions.
Sorry, my.
I'll try. I'll do something again. Tell me when.
All right. One, two, boom.
Chris, and we, as we're talking about TAVR and so forth, it'd be interesting to see from your perspective on the clinic side, the referral process, what questions patient asks our team. Maybe talk a little bit about from the staff perspective.
For sure. So when we get a referral for aortic stenosis or for a transcatheter aortic valve replacement, maybe from another provider or consult for that, we have a multidisciplinary approach to that just because patients do have a lot of questions. We need to make sure that Dr. Sankara is able to answer those questions, but we also have a clinic MA that is dedicated to just kind of managing the flow of those patients from the ground up when we receive that referral, alongside our structural heart nursing coordinator, who is Liz Bear, and she is amazing. She's very involved from start to finish. If patients have questions, they are always able to ask her. And patients have a lot of questions, I think, about timelines for when they can do this, what types of valves, why they're a great candidate for this, and how they should proceed with their care in the future, what to expect in the future, just where many may not know much about it prior to being introduced to this. And so what would you add to that?
The biggest surprise to me about what patients are concerned about, especially when you're dealing with older patients, is this tendency to, one, dismiss their symptoms, thinking that this is probably related to old age, and also this concern about heart valve replacement or heart valve surgery. They're worried about how much of a burden they'll be on their support system. I think that's a big question in patients' mind that I've realized. Obviously, they're concerned about the type of valve and the surgery and the risks and benefits and all of that, but their primary questions are related to the recovery time, the time involvement for, not mainly for themselves, but for their support structure. And that's a very valid question. And it's significantly different between open heart surgery and transcatheter aortic valve replacement. We tell our patients that this is a process which involves multiple steps, and we try to minimize the number of steps as much as we can for patients, make it convenient. And some of the steps are obviously, one, we need imaging studies. We also do angiograms to check for any heart artery blockages before we proceed with valve replacement. So we try to arrange the angiogram and the imaging studies on the same day, so it minimizes trips for patients. They need to meet the rest of the team members. So if they start out with me, they'll meet the rest of the team in another setting, which could be they'll meet the rest of the team in another setting, which could be the same setting when they come in for the angiogram, again, to minimize and make it convenient for patients. We have patients coming in all the way from Monticello, San Juan, and we try to minimize the number of trips they need to make to the hospital before they can actually be scheduled for valve replacement. And once they're good candidates for transcatheter valve replacement, the process is usually they come in for the valve replacement, they get the replacement done. More than 90% of our patients go home the next day. They're able to get up out of bed and walk around typically the same day. And the next day they work with cardiac rehab and they go home with family support. I think that's one thing that many people are concerned with in terms of how many days they need to be in the hospital. How about the family members they're already caring for at home, how to arrange support for them, things like that. So that's definitely one concern. The other concern is obviously the risks. This is open heart surgery. There are risks associated with it. The risks are comparable based on multiple studies we have done. Some show TAVR is a little bit better, some show surgery is a little bit better, but I think overall the data suggests that both are similar in terms of risks, which is about 2 to 5% risk of something major happening, like a major heart attack, stroke, or death on the table. There is about a 5 to 15% wide range, but up to 15% risk of needing a pacemaker after the procedure. So we typically monitor patients in the hospital while they're in the hospital to see if they'll need a pacemaker. If not, we typically send them home with a monitor, so we continue to monitor them for up to 30 days after the procedure. But typically, the need for a pacemaker is identified within the first 24 hours, so while they're in the hospital. If they do need a pacemaker, it is a much simpler surgery compared to valve replacement, and we get that done before they leave the hospital if they show that they need a pacemaker before they leave the hospital. I think those are some of the things that people tend to be concerned about.
You hit on some of the benefits that I think are really interesting as I've watched. So I was fortunate enough in my career early on, about 13 years ago, to be a part of one of the original research trials. And it's funny because our patients would be very frail, elderly population, and they weren't even surgical candidates back then, right? And now, to your point earlier, we have approval to do low-risk patients. But the thing that's fascinating, even if you talk to our cardiothoracic surgeons here, part of our team, let me just back up a little bit. So we just celebrated that 500 TAVR you mentioned earlier. So we at our facility have implanted 500 aortic TAVR valves, which is fantastic. And it's interesting how committed our cardiothoracic surgeons are to this process. The other thing that was fascinating, we took this group picture, and there was like 30-something people, and probably throughout the whole day, you probably were at 50, 60 people that came through. And one of the things I just want to hit on from a benefit perspective that's similar to surgical is it's very much a multidisciplinary team, right? And come back to the surgeons, it's fascinating. Some of them will encourage their patients to have a TAVR versus surgical, right? Depending upon those patients and what they need and what's best for them. Because in a surgical setting, right, you're in the hospital post-surgery minimum to 5 to 7 days. And, TAVR, we're not doing it, but there are, it's almost same day practically, right? And I don't know that that's necessarily the best way. We could talk through the research in the future. But for sure, there's great opportunity where it's a day or two, right? I think our average length of stay here is about one. It's like literally less than one full day of 24 hours. It's amazing how we've come and, brought that service here. So I think that's a big benefit to our team is they're not sitting here, our patients more so. They're not sitting here for 5 to 7 days in the hospital. That care from family, they're sitting here, they're taking work off. From a TAVR perspective, they may take a day off, but or two, but they're home after that, which is a very fascinating benefit to our community and our patients. So not only is it fantastic because you have that multidisciplinary team that's there supporting everybody, but you have these other nuances of benefit that TAVR provides for the appropriate patient, right? Obviously, there are still some ones that need surgery, and we have a phenomenal program here for that. We can take care of those too.
All right, so that was awesome. Two final questions here I think that would be good to go through. So one, maybe at the end, Crispin, if you want to, or maybe somebody could tee it up to ask you, if a referring physician has an AS patient, how do they contact your clinic? Maybe what we could do is we could put like an email address for whoever at the bottom. Before that, I'm not sure who wants to ask it. Maybe Mitch, maybe you ask Dr. Sankar. So after a patient has received a TAVR, how does referring cardiologist, what is their role? So what is their role in follow-up? I think we've got different areas that they're afraid that their patients are going to get stolen from them. So what does follow-up look like? How is the referring involved? And then what do they need to be monitoring, right? At what point, what is a indicator to them that, hey, they need to send that patient back to you. Something could be going on.
You want me to ask those questions, or
So how about you ask Dr. Sankar the question of, what is the referring's role in that patient's care after they've received the TAVR? And then, what are they looking for, and at what point, do they want to send it back to you? And then we can do a pause, but then before you keep going, Kristen, maybe the last piece is if a patient has AS, how do they get in touch with you guys?
Okay.
Like, how do
that's great.
Whenever you guys are ready.
Okay. I probably do have a hard cutoff in 10. I'm super sorry.
10:30.
Give me the cue.
1, 2, 3.
You don't have to do that. You'll catch it. So, Dr. Sankaris, we've gone through and we've explained all these things. Maybe talk a little bit. One of the challenges we've seen throughout our process of instituting a TAVR team and a structural heart team is, you were asking both cardiologists and some primary care community members to refer into this clinic, right? There's always that apprehension that they're going to lose their patient, right? They're going to lose them in the process, the workflows, and the communication back and forth. Maybe talk about some successes you've had, or maybe the process of how you go about communicating with those folks so that they don't have to worry about that concern.
That's a great question. This process of taking care of these patients is a team effort, and the primary care physician or the referring cardiologist is an integral part of that team. Primarily because once the patient gets the aortic valve, we see them at 1 week and 1 month intervals to follow up and make sure everything from a valve standpoint is going well. And the 1 month interval will discuss the monitor that we've been using so far to see if there was any additional indication that the patient needed a pacemaker. Once that is taken care of, the patient goes back to their primary team, either the primary cardiologist or the primary care physician. And they are integral in this whole team-based approach in continuing to follow up with the patient and communicating with us in terms of any new symptoms that may arise. We don't anticipate these valves having any issues, but if the patient starts developing new chest pain or shortness of breath or dizziness, or there are further signs that they're concerning for them being related to the heart, we want them to be communicating with us so we can see them again. Our goal and intention is not to continue to see these patients forever. So we want to include the primary team and the primary cardiologist as much as we can in this process as early as possible. So for example, when I get patients from Monticello, we don't anticipate those patients coming back to see us within a week. So we use the primary care physicians there to do that 1 week post-operative visit. And we are always readily available on the phone for any questions that may come at that visit. And we try to see them at the 1 month mark. And if they're doing well, they continue to follow up with their primary care physician. So this involvement from the primary team is really important to us, and we've done everything we can to make it convenient for the patients so they don't have to keep doing these multiple trips coming to Utah Valley Hospital to see us. Kristen, can you talk a little bit about if a referring provider has a patient with aortic stenosis, what's the process in getting in touch with us, or how do they send the patient to us?
They can always contact our office by phone. It's at 801-357-4600. They can also fax some patient information over, any imaging that they've had over. We can always request any physical imaging copies and have that pushed through. But sending that referral by fax is probably the easiest way, and we can make sure that we include this fax information with this podcast.
Excellent. One final thing I wanted to highlight was when to send these patients to see a structural cardiologist. I would say the best time to send them is as early as possible. What that means is once you hear a murmur or once you start noticing patients having symptoms suspicious to be related to the heart, send them over. We'll take care of the investigations and we'll figure out if they need an intervention or if they need just follow-up. They'll come back to you and we will continue to monitor them periodically in coordination with you and your team. Thank you.